Hello to everyone. My name is Chris Taylor. I'm one of the clinical pharmacists here, and I want to take a few minutes to talk to you about some revisions that we've made to our heparin protocols. I know many of you who have used the protocols over the years have expressed some concern about some confusion, and we have taken a look at those and revised them to try to improve the clarity of those orders. The limitations of our current heparin protocol orders are actually quite numerous, but I think the major ones are as follows. One, there are multiple, quote, orders present. First of all, there's a medication order for the heparin drip itself. That's necessary for you to scan it in BCMA. But then there's a nursing text order that's separate from that has dosing guidance, such as dose adjustments and even initial dosing. And then there's even a separate text order that gives the monitoring recommendations, what lab tests to order and how often to order them. The second limitation is the inability of the Alaris pump to truncate doses accurately in ACS patients who are heavier in weight. Many of you who have used the Alaris pump for acute coronary syndrome in patients that are above, say, about 84 kilograms have noticed that the pump instructs you to manually set the initial dose at 1,000 units an hour or 10 mils per hour. However, that does not coincide with the units per kilogram per hour dose in the protocol, and that has created confusion as well. The third is that there is some confusion whether we should be using the Alaris pump in a weight-based or non-weight-based mode. Those of you who have used the vascular protocol know that the dose adjustments for that protocol are not made in weight-based increments. They're not in units per kilogram per hour, they're in units per hour, such as increase or decrease by 100 units per hour or 200 units per hour. And that has created some confusion as well. And the last is the inaccuracy of the current lab test we use, the UFH anti-10A, in patients who have recently taken newer agents such as apixaban or rivaroxaban. And I'd like to expound a little bit on that because I've had a lot of people ask me why that's so. The newer agents such as apixaban, rivaroxaban, edoxaban are collectively called direct-acting oral anticoagulants, or for short, DOACs. And the UFH anti-10A assay is not accurate in patients who have recently taken these medications. If you look at the mechanism of action of heparin in this diagram, heparin binds to a protein called antithrombin 3, and that complex then subsequently binds to factor 10A and also thrombin. Well, when we use the anti-10A assay to monitor our heparin, we're actually looking at the number of 10A molecules that have been inhibited by the heparin. And therefore, we can use that as a surrogate of how anticoagulated the person is. The direct-acting oral anticoagulants, okay, or the DOAC agents, such as apixaban, rivaroxaban, and edoxaban, they bind directly to factor 10A, and they inhibit it and produce anticoagulation. So you can see in patients who are on these medicines, it can interfere with the accuracy of the anti-10A assay because the anti-10A assay now is not only monitoring the effect of the heparin that we're using, but also residual effects from the DOAC agent that the person was on. And just to show you, these on the left are some subsequent lab tests from a patient who came in on one of the DOAC agents and then got started on a heparin drip. And you can see, and many of you probably have witnessed this firsthand, that the UFH anti-10A here was greater than 1.1, and then subsequently greater than 1.1, and then subsequently greater than 1.1, and so on. There's even a comment that says the UFH results can be falsely elevated due to apixaban use. And what I'd like for you to notice is that the DOAC agents have long half-lives, about 10 to 12 hours. And therefore, the UFH anti-10A level may be elevated even though the full anticoagulation effect of these oral agents has waned away. For example, when you stop taking apixaban, the serum levels fall. However, there may still be some residual serum levels there that could affect this anti-10A assay, but they're not high enough to produce full anticoagulation effects. The persistently elevated UFH anti-10A levels suggest that the heparin infusion is too high. However, because the UFH anti-10A is being falsely elevated by the residual subtherapeutic now levels of the DOAC agent, the patient is actually likely under anticoagulated, not over anticoagulated. In these patients who have taken these DOAC agents recently, say within about the last 96 hours, APTT, easy for me to say, testing is more accurate for monitoring heparin in those patients. So how have we revised the protocols? As I said before, these are the goals. One was to consolidate the heparin drip orders into a single medication-based order that would be easier to follow, incorporate the initial dosing, the monitoring, and the dose adjustments all in the same place, would be visible in BCMA and not require you to toggle back and forth to CPRS. And actually, once the heparin is discontinued, there would not be these residual nursing text orders that remain active, which could be confusing for, say, someone coming on after you, where the medication order for heparin is discontinued, but the nursing text orders are still active. The second goal was to avoid confusion with the Alaris pumps, where doses currently have to be manually changed to avoid exceeding the maximum initial doses, as we talked about, such as heavier patients with acute coronary syndrome when the initial bolus and infusion have a maximum value. The third goal was to provide an option for APTT testing and monitoring in patients who have recently, i.e. within the last 96 hours, taken the newer DOAC agents such as apixaban, rivaroxaban, and edoxaban. And the last is to improve everyone's satisfaction with utilizing heparin infusions safely and effectively and to decrease errors. As I stated, on the left is the new consolidated heparin medication order. And I know this is somewhat busy, but I want to go through each section and show you. You can see on the first line is the indication that the heparin drip was ordered for. In this case, a patient with acute coronary syndrome. You can also see what type of monitoring is going to be used. The anti-10A monitoring will be used here. On the second line, you see the standard heparin concentration that we use, 25,000 units and 250 milliliters. The third line, you see the patient's weight, both in pounds and kilograms. On the fourth, and as I say in the blue box to the right, it's very important that we verify the patient's weight, that it is generally correct, because this weight is going to be used to calculate the doses that are going to be given. Watch out for things like pounds and kilogram mix-ups. The next line shows the initial bolus. And you notice that it shows 60 units per kilogram, but notice that in the box I have marked 4,000 units. And then look at the initial infusion rate as 1,000 units an hour. In the green box to the right, the bolus and the initial infusion rates are there. Now, unlike in the past, this is going to be a change. We will now use the calculated doses, what I have in the green boxes, as we program the Alaris pumps. We'll go over that a little more in the following slides. The next section shows the monitoring. In this case, the anti-10A level is being monitored, and so it tells you to order it 6 hours after you start the heparin drip or after any dosing change, and so forth. It is not in a separate text order, but it is right here with the order for simplicity. And then in the bottom section, you see the dose adjustments. If the UFH anti-10A is low, or if it's high, or if it's within the goal range. And again, notice that I have placed the calculated doses in the green boxes. Some protocols are going to use the UFH anti-10A lab for monitoring, and some are going to use the APTT. So make sure to follow the order. And again, note that we're going to use the calculated doses.